crossing, changes are persisting in some of the we see.
So post-COVID, we are picking up more COPD, but this is primarily reserved for obstructive airway disease. COVID leads to a restrictive lung disease, so possibly the target populations are different, and we are able to pick up more patients because of more awareness, and people are definitely now coming forward and they want more.
Thank you. Are there any questions?
Cool. Ma'am.
Once you shrink one side, one part of the lung, won't other villi open up?
No, ma'am, that does not happen. So we are treating the disease segment, which is pressing the normal lung. So this we are doing when it is heterogeneous. That means some part of normal lung tissue is available. We are not treating the normal or healthy lung. We are treating the most diseased segment, and we are not treating when the whole lung is damaged. Generally.
Yeah, I have a question.
Sir.
What is the exact follow-up protocol after the burning procedure?
So we follow up the patient. Initially, we would keep the patient in hospital for about 4 to 5 days. The patient is discharged and followed up weekly for about 2 to 3 weeks. And once they are stable, it is just like a regular COPD follow-up, which is maybe say once in 2 to 3 months, sir.
And what's the exact outcome?
See, the outcome is improvement in the symptoms, improvement in the walk distance. That is the main aim of the procedure, sir.
Thank you.
See, this procedure is to decrease the suffering and increase the quality of life. It has nothing to do with cure of the disease. Patient still needs to be on medications, but those medications are expected to come down with this procedure. And coming back to ma'am's question, yes, it does happen that the other side will increase. So exact increase in lung volume never happens. So he has also shown in that PFT that exact increase will never happen because some other areas will definitely overinflate. But it's an overall improvement in the symptom, which is the target.
And you can treat these patients later on when they are having hyperinflation on the other side. So a couple of patients, we treated the right upper lobe, and later we treated the left lower lobe because the patient showed a significant improvement.
So far, there is no experience of doing it after few years, repeating it after a few years. But this procedure has the potential of doing later on also, because COPD is a progressive disease. So in a progressive disease, you expect that other areas will become disease and his symptoms will again become worse. So maybe in future, this procedure can itself be repeated. So that is the advantage of this.
Rightly put, sir.
So if there are no other questions, we'll end this session. Thank you.
Thank you, respected Chairperson, Dr. Abhinav, for a really interesting session. For the next session on refractory anemia in children, coming back to pediatrics, opening the mystery box, I'd like to invite Dr. Dinesh Kaul, sir, Senior Consultant, Department of Pediatrics, and Dr. Nitin Gupta, sir, Senior Consultant, Department of Hematology, and Dr. Manas Kalra, sir. Chairpersons, please kindly introduce the speaker.
Thanks for inviting us over here. Dr. Manas Kalra doesn't need really any introduction. With Dr. Anupam Sajdev and they are the pillars over hemato-oncology division, which is well known over whole of North India, doing not anemias, thalassemias, refractory anemias, doing BMTs, treating all ALLs, AMLs. So today, as a part of for the general practitioners, I think he will discuss about refractory anemias in children. So let's see what is newer modalities, what are the genetic conditions. Dr. Kalra, go ahead.
So a very good morning to all of you, and welcome to Gangaram CME. And it's really an honor to be here with this galaxy of speakers from Gangaram who are presenting the best of best. And, you know, I thought that we have a mixed crowd and there may not be many pediatricians here. So I thought I'll keep the tempo of my talk to a general anemia talk, which is relevant to a physician, a medicine specialist, a surgeon, or even if I'm lucky, maybe a pediatrician who's in the crowd. Dr. Nitin looks after adult hematology. Dr. Dinesh is involved in a huge amount of thalassemia work, and I look after pediatric hematology, oncology, bone marrow transplant, and children who are born with immunodeficiency disorders. And this is, the hospital where we work, and it's indeed a privilege to be a part of this hospital. So why anemia? Despite all the attempts of government of India, the anemia assessment still shows that 70% of children, teenagers, pregnant women, lactating women, adolescent girls and boys, they are anemic. So isn't this sad that, we have had like around 15, 20 programs over so many years to look after anemia, but we are not able to fix this. And can you believe it that if you are anemic, and if you're a young child with iron deficiency anemia, your IQ may be less by 5-10 points as compared to others. So how do we expect India to be shining and to be at the top if all our young children are anemic and are iron deficient? So I think the focus has to be on anemia in this country, and the government with the Anemia Mukt Bharat Abhiyan is trying to, really make an impact which has not happened over the last 40-50 years, and we have started to see some trends of improvement of anemia in patients. And the commonest is iron deficiency anemia, and you look after this all the time. You have a patient with low hemoglobin, MCV is low, RDW is high, RBC count is low. And you do basic blood tests, you find low iron, low ferritin, and all the other markers, and you know that this is iron deficiency anemia. And you treat these patients, the smear will show a microcytic hypochromic picture, and you do all the basic investigations, you treat them. But what happens, often we start them on iron, and then we forget, or we give them B12, folic acid, or whatever, and then we forget, is the patient responding appropriately or not? That is very important because, I understand that 70-80% of Indian population is nutritionally anemic in that category. But if they are not responding, we need a specialist opinion. Why? Because some of these conditions may mimic nutritional anemias, but are actually not nutritional anemias. And I'll show you some case vignettes. So this 7-year-old boy who came to us with lethargy, pallor for a few months, has got microcytic hypochromic anemia. It's not responded to iron, He's been taking iron for a long time. There are some joint pains, there are fevers. And you look at the picture and it looks like an anemia with microcytosis, and you think, oh, this is iron deficiency anemia. मैं iron का सिरप बदल देता हूँ, मैं गोली बदल देता हूँ, आप iron ठीक से नहीं लेते होगे, दूध ज़्यादा पिला रहे होगे. And months and months are going on in that discussion, but the patient is not really responding. And once he comes to a hematologist, he listens about bone pains, joint pains, child with anemia. First thing is he does a bone marrow. Why? Because we are really scared of missing a leukemia. And leukemia is a big common problem that, a pediatric hematologist sees. But to his surprise, when he looks at the marrow is kind of iron overloaded. And that is when he starts wondering, what did I miss? What was this child actually having? And why is he or she not responding to treatment with iron? And then, a good, humble medical resident says, sir, bachcha to bahut chota hai aur BP bahut high hai. So, the crux is in a good medical examination. You may be able to do fancy tests, but you miss certain subtle signs in children. And, this child actually had a CKD. It was asymptomatic. There was a chronic kidney disease which was presenting as anemia. And there are many conditions which can present as anemia of chronic disease. And we need to be aware. And, this child had CKD and is with the nephrologist and is doing okay. But, the focus was anemia here, but the condition was originating from kidney. This is a 2-year-old child who presents with wheezing for a few months. Again, iron deficiency. So, bacha doodhi doodh peeta hai. So, that's a typical story in India. We focus too much on milk. And when we think, okay, that history is compatible with what you are seeing on the bloods, you think it's iron deficiency anemia. You're treating iron deficiency anemia, but hang on, the child is not responding. That's the time when we need to go back and see, are we missing something? What is this asthma story going on? And these are all real cases that, we have seen. And you look at the blood picture, typically iron deficiency anemia. So, whenever there is anemia, think of these causes. क्या खून कम बन रहा है? क्या खून कहीं ज़्यादा रिस रहा है? यानी is there a blood loss? और क्या खून ज़्यादा टूट रहा है? Is there hemolysis going on? And that is what was happening in this case. The child was actually losing blood. But where was the child losing blood? What is the story of asthma going on? The child was actually losing blood in the lungs. The child has a condition called idiopathic pulmonary hemosiderosis, where you keep losing blood in your lungs, and that is why you are recurrently iron deficient and in an iron deficient anemic state, and you keep treating with iron. But what you really need is to prove this condition, which we did by doing a bronchoalveolar lavage, and you give them steroids and they get better, and your requirement for iron therapy goes really down. Don't forget lead poisoning. Although the pipes in our homes are no more lead pipes, but this is an important condition, and we recently diagnosed a doctor with lead poisoning. She was anemic for a long time, and she was on this kind of a herbal therapy, and she actually had very high lead levels. And often we see children with hookworm infestation, which again can lead to anemia. Third case is that of a 4.5-year-old child who presents with fever, cough, there is pallor. Again, there is, the growth is very important. The growth was faltering in this child, the height was less, the weight was less, and a spleen tip was just palpable. CBC picture was very typically that of an iron deficiency anemia. The child was treated with iron, but look at the response, has finished 3 bottles, nothing is happening, no gut symptoms, nothing else, persistently anemic. So, whenever you have such a child with anemia which is not getting better, again, think of other causes. And in North India especially, celiac disease is an important cause for refractory anemia. It can be, it's typically microcytic iron deficient, but you can even have B12 folic acid deficiency. And a simple test, of TTG, you can pick this, and then you do a biopsy, and it's celiac, you give them gluten-free diet, and they are well. Sometimes we see inflammatory bowel disease, intestinal polyps, leading to anemia again and again in children. And trust me, it's not only iron therapy which is going to help them. Treating the local cause will improve their condition. This is a 2-year-old boy with history of recurrent blood transfusions and developmental delay. So, again, there are 2 systems involved. There is anemia, there is neurological symptoms. And, you typically see an iron deficiency picture, but what you look at, ferritin is very good. So ferritin is the most sensitive marker for iron deficiency. If a patient is unwell, the ferritin may be high because of the inflammatory process, but generally ferritin reflects your stores of iron. And in this case, we did a bone marrow and picked ringed sideroblasts. So this child has a sideroblastic anemia, and we just gave pyridoxine supplementation, and all the neurological complications in this child resolved. So again, you have to think out of the box when your child is not getting better. Alpha thalassemia, is very heavily underdiagnosed in our country. So if you have a microcytic anemia which is not getting better, you have ruled out beta thalassemia, we need to evaluate these patients for alpha thalassemia. And in Ganga Hospital, we have got all the genetic backup to diagnose these conditions, and the treatment management is very different. This is a 4-year-old child with anemia, microcytosis. Again, lots and lots of iron therapy. Child is not getting better. There is no organomegaly. HPLC is normal. TTG is negative. Stool for occult blood is negative. Autoimmune workup is negative. Chest X-ray is also normal. So all the conditions that we talked about have been ruled out in this condition. And we found out a very rare condition. It is iron refractory iron deficiency anemia. And we did a genetic test which picked this kind of a mutation where you keep giving iron to these patients and it does not work. What happens is that they've got very high hepcidin level, and because of this high hepcidin, the iron is not able to go into the plasma, and what you need is parenteral iron therapy for these patients. Another case is interesting case. You look at a typical microcytic anemia here. The child has low MCV, high RDW, you diagnose iron deficiency, you give them iron, and the child gets better. But what happens? The hemoglobin stays around 11. You can see that the MCV is still 65. The RBC count is very high. So, in North India especially, around 4% of our population is thalassemia minor. So please don't forget this condition. If you are giving iron, the patient gets better, but the hemoglobin kind of is stuck at 10, 11, and you have microcytosis persisting, and your RBC count is high, please think of thalassemia minor, because if two thalassemia minor get married, the baby can have thalassemia major, which will require a lifelong blood transfusion. So microcytic anemia can have a lot of DDs. And just a very quick mention about macrocytic anemias. We see these typical picture, and it's B12 deficiency. There are hypersegmented neutrophils. You see all the other findings, and it's B12 folic acid deficiency. Children may have knuckle hyperpigmentation. Marrow may confirm megaloblastic anemia. And in these cases, giving B12 folic acid supplementation is fine. And you're happy and your patient will get better. But what if he or she does not? So I'll just show you a couple of cases. Like this patient, who came to us, has persistent macrocytosis. And you are treating this patient with B12 folic acid. He's not getting better. The child has short stature, the other cell lines are also getting down, and then we diagnose that this case has a Fanconi anemia. So these are inherited bone marrow failure syndromes where again your patient can have macrocytosis, but if your B12 folic acid is not helping these patients, please refer them to a specialist to find out the condition. And I'll not go in detail, just tell you the cases. One is hypothyroidism.